Let's start the session. Hello everyone. This session is to have a deep understanding of the current status and the challenges of antimicrobial resistance. I'm Professor Asai, a moderator of this session, United Graduate School of Veterinary Science, Kyiv University. For control of infectious diseases and AMR, One Health approach is advocated, that is a collaborative effort of researchers in human medicine, veterinary medicine, and environmental study. In this session, Professor Sugai, National Institute of the Infectious Disease, is going to talk about One Health in human medicine, and Professor Usui, Lucknow Gaku University in animal medicine, followed by general discussion. Time is limited. Let's welcome Professor Sugai, Director, Antimicrobial Resistance Research Center. The title is Action Plan on Antimicrobial Resistance in Japan, Past and the Future. Thank you very much. I'm Sugai, National Institute of Infectious Disease. First, I'd like to share the screen. I'm given about 30 minutes, so I'd like to discuss AMR measures in Japan, past and the future. For the presentation, particularly on past and the future, I received the cooperation of Dr. Yoshiaki Gu, AMR Clinical Reference Center of National Center for Global Health and Medicine. I would like to take this opportunity to thank him. AMR is a global issue. You may see this slide oftentimes, but annual mortality of AMR is about 700,000 cases in the world. We have been suffering a COVID-19 pandemic from early 2020, with the mortality so far exceeding this number already. But without any further action against AMR, at the present moment, some economists estimate that 10 million of people in total would die of AMR in the coming 30 years before 2050. This number is greater than that of cancer, 8.2 million. This indicates how serious this AMR problem is. However, as compared to COVID-19, AMR is a less visible issue. COVID-19 pandemic started in early 2020 out of the blue, but its pathogenic nature is obvious from the beginning. Its high contagious rate is reported in the media, and fatality is repeatedly reported in the media as well. On the other hand, AMR tend to keep a low profile, particularly pathogens in issue is less virulent and almost unharmful in healthy people. If something happens because of AMR, that should be in hospitals, again less visible to general public outside hospitals. Its fatality is less obvious as well. This AMR problem is too difficult to be solved only by professionals of human medicine. It embraces too many challenges extending beyond human medicine. In that sense, COVID-19 can be likened to tsunami, and AMR to elevation in sea level due to climate change. In Japan, various actions have been taken already against AMR. In 2014, WHO conducted the first survey to understand the status of AMR in the world, and reflected its lack of preparedness. The World Health Assembly subsequently made the decision to take solid action against AMR and adopted the Global Action Plan in 2015. In response to this, Japan developed AMR Action Plan in 2016 under the initiative of National Commission of AMR Countermeasures. In the same year, the General Assembly of United Nations put AMR on its agenda. In the following year, 2017, Japan established two institutions based on its action plan. One is at the National Center for Global Health and Medicine, AMR Clinical Reference Center. Another one is AMR Reference Center at National Institute of Infectious Diseases. They are appointed to be in charge of development of national policies on AMR. After that, meetings are held almost every year to discuss AMR, and the AMR data are collected for One Health approach with the annual release of report on AMR One Health surveillance. This action plan is a 5-year plan until 2020. So the year 2020 is the last year of the action plan, the first action plan from 2026 to 2020. The second action plan was supposed to be developed on the result of the first plan, but because of COVID-19 pandemic, one more year was added before the formulation of the next action plan, which will start from 2022. Japan's action plan focused on 6 areas with respective goals set forth. They included public awareness education, trend survey and monitoring, prevention and control of infection, antimicrobial stewardship, research and development, and drug discovery and international cooperation. These goals are set forth with specific actions in this plan. As I said, this plan is unique in that it involves human medicine and also other disciplines such as environment, agriculture, livestock industry, fisheries, food, and so on, surrounding humans. Without the engagement and involvement, it is too hard to accomplish the goals of this action plan. And that is the basic concept, and this approach is named as One Health approach. I'm going to briefly explain the goals and what we have done in these 6 areas against AMR. The first one is public awareness. This is to deepen the knowledge and the understanding of AMR in general public and to provide a training education to healthcare professionals as well. Is it true or not that antimicrobials or antibiotics are effective against the virus diseases? How many people responded with the correct answer no is compared among different countries in this chart. As compared to other Western countries, Japan's rate is low, much lower than theirs, 23.1%, suggesting that the understanding of the true nature of AMR is not yet well understood in Japan. In response to this result, AMR-CRC have been providing information and education for general public together with the Cabinet Secretariat. Public awareness and education that is led by Cabinet Secretariat and training and education for healthcare professionals by AMR-CRC. Various different methods had been taken, such as the posturing, media advertisement, and others. Almost every year, we did the survey and asked the same questions about whether antibiotics are effective treatment against the common cold and flu till 2019. But in 2019, we realized that there had been a little improvement of the public awareness on this issue. Our short-term strategy was not enough to improve public awareness. This is not an easy task. We need to come up with ideas to educate people based on the long-term strategy. It is quite clear by looking at this chart. Nowadays, people and healthcare professionals have an increasing chance to be exposed to information of actions against AMR, and appropriate use of antibiotics, but still it is difficult to penetrate correct understanding through the community. Leading the interested to correct knowledge and behavior change still needs incessant effort and activities of ours. For healthcare professionals, one challenge is to fill up the gap in awareness among different institutions as well as professionals. Now, facing the COVID-19 pandemic, we can now expect hand washing and other behavior changes in people, which is helpful for AMR control as well. The second one is the trend survey and monitoring. That is to monitor appearance of AMR and the use of antimicrobials on a continuous basis and capture changes and a potential expansion of AMR. We can now measure the volume of antibiotic sales countrywide. From 2016, the sales of antibiotics have been declining, probably reflecting a better stewardship of antibiotics. And using the information of reimbursement claims and health checks for metabolic syndromes, we can visualize the volume of oral and injection drugs in Japan. One thing we now understand is that medications may be more often prescribed in west part of Japan. Better visualization of this kind of data is one of the successes we have achieved in this action plan. The Ministry of Health, Labor and Welfare have had the local Institute for Health install AMR test facility from 2017. That is to enable PCR-based surveillance for CRE pathogens. As a result of that, they can monitor the number of CRE infections and its distributions, the identification of the pathogens, and detection of responsible enzymes every year from 2017. This project is almost completely this project is almost complete all over Japan. CRE infections are supposed to be reported to public health centers. The pathogens are now tested at the local Institute for Health and Public Health Centers starting from 2017 and making data of pathogens as well as that of patients available together. National Institute of Infectious Diseases use these sets of data for risk assessment. We have established based on that the mechanism to monitor the issue of AMR with its exact locations in Japan. Once an outbreak of AMR bacteria occurs in one region, the necessary information and alert signals are shared among hospitals and public health centers and local institute for health in the region. If necessary, FETP is mobilized. The result of a genome analysis done by AMR Research Center is also returned to these medical institutions. That kind of effort supports the early detection and early termination of outbreaks of AMR bacteria. I believe this system works quite successfully so far. There is another surveillance under MHLW's initiative named Janice. We encourage hospitals, which is about 8,000 in number in Japan, to join this Janice network on a voluntary basis and provide AMR information to us. We collect these data and build the nationwide database. Comparative information is provided so that each hospital uses this information as a benchmark. Janice started in 2017. Already, about 15 years have passed with the memberships of 70 to 80% of hospitals with over 500 beds, the number of hospitals with less than 200 beds has also been increasing rapidly after JANA's membership is mandatory element to have additional reimbursement of infection control service. This helps a lot for us to obtain data and information from all over Japan. On top of this kind of surveillance information in human medicine, probably Professor Usui is going to mention this later, the information of surveillance in livestock industry, agriculture, and environment, all these surveillance information is now put together on a website operated by AMR CRC. This one-stop service is called AMR One Health Platform. Various pieces of surveillance information in Japan is accessible on this single website. This is quite an accomplishment. One of the things we have achieved under the AMR action plan. If you visit this site, you can access to the data and information such as resistant rate of certain bacteria, resistant rate in bacteria from animals, comparison between human and animals, the volume of antibiotic use or the consumption of antibiotics in animals, and how they change over time. For example, this is about the rate of MRSA. You can tell the prefectures with a higher rate of MRSA and the annual changing of the rate of MRSA. And by clicking buttons, you can probably find more detailed information of your interest. So this site provides very much information on AMR. In this action plan, in regard to surveillance, the use of antimicrobials in humans, analysis information in patients, information of infections, particularly AMR bacterial infections in human medicine. If you are interested in animals, the use of antimicrobials for food animals, the detection rate of AMR bacteria in food, such data are collected and summarized as one health surveillance report, being published from 2017. As this report is published every year, I think we are going to see the publication of a 2020 version as well. Nationwide surveillance on AMR has become enriched like this. It is true that we are able to have a good understanding on the current status of AMR. This is not limited to human medicine. We are beginning to share information with experts in the areas of animal health and the environment. For further analysis, surveillance needs to be conducted in a steady manner. How to leverage the result of surveillance for future policies, that is one of the challenges we need to tackle. Next is the prevention and the control of infectious diseases. The goal is to prevent and control infections to suppress the expansion of AMR bacteria. There exist 3 laws as the basis of administrative policies of in-hospital infection control: medical service law, health insurance law, and infectious disease law. The medical service law was revised in 2007, and in-hospital control of infection was incorporated in the law. In 2014, actions to be taken in response to an outbreak of bacterial infection with AMR genes detected. In regard to the health insurance law, in April of 2012, as I mentioned before, reimbursement claims for infection control 1 and 2 were added, reinforcing the mechanism of networking at local levels. The infectious disease law classified CRA and MDRA as a class 5 bacteria in September 2014 and made it mandatory to check AMR genes. This is the positioning of administrative policies. For small and medium-scale hospitals, a guidance book to control AMR bacterial outbreak has been released by Infectious Disease Education Consortium. It emphasizes the importance of collaboration of local experts. Once they detect AMR bacteria in local hospitals, they are expected to work together with the local healthcare centers and other experts to tackle. In order to support such local efforts, AMR CRC of National Center of Global Health and Medicine started the J-Cipher, an infection control networking platform. J-Cipher stands for Japan Surveillance for Infection Prevention and Healthcare Epidemiology. It is a mechanism to share information at local levels in regard to the uses of antibiotics, detection of AMR bacteria, and others. The basic information provided through J-Cipher include clinical practice for infectious diseases, proper use of antibiotics, actual prescription of antibiotics, infection control teams, infections in healthcare from JANICE, and AMR of bacteria, again from JANICE. Sharing information of this kind help them to control infections at local levels. The new mechanism for these purposes started this year. I think J-Cipher is another achievement that we have made. We have been building up various measures over time to prevent and control infections. Such continuous efforts are critical. In addition, other systems to reduce the burden on healthcare professionals and the guidance tools such as J-Cipher are under development. Besides further development of system tools, collaboration and networking at the local levels need to be further encouraged, and the region-specific means may be necessary for that. Next is antimicrobial stewardship. This is to promote proper use of antimicrobials in healthcare business, livestock industry, and fisheries. For humans, the guidance of proper use of antimicrobials has been published by MHLW first in 2017 and revised in 2019. The digest of the second version is also available with the text for babies and children added. Particularly in pediatric outpatient care and attending children by family doctors, proper use of antibiotics is now subject to additional reimbursement of the cost. After the introduction of this new category of reimbursement, the prescription of antibiotics is reduced all in all, suggesting the effect of this health insurance policy in some way or another. As part of the revision on requirements for reimbursement related with infection control, setting up of an antimicrobial stewardship team has become reimbursable. So far, we have an infection control team in hospitals consisting of physicians, pharmacists, clinical technicians, nurses, and clerical staff. A team for antimicrobial stewardship is a similar teamwork effort which is now reimbursable. One example of this kind of effort is the statement for antimicrobial stewardship in the package insert of medicines. It says that for treatment of pharyngitis, laryngitis, tonsillitis, acute bronchiolitis, etc., the guidance of antimicrobial stewardship needs to be referred to. The use of antimicrobials should be decided only when they are truly considered necessary and appropriate. This statement is written in the guidance of antimicrobial stewardship as well as in the package inserts of medicines. This is a good example of collaboration. Release of discount news and incorporation of additional reimbursement for antimicrobial stewardship. These are the main fruits of this action plan. AST starts in many hospitals. ICT and AST actions of both teams are now building the foundation to promote antimicrobial stewardship. Specific goals should be set and promoted to different types of hospitals and clinics in the future. Next is R&D and drug discovery for research on AMR and development of measures for prevention, diagnosis, and management of AMR microbes. R&D need to be promoted. New medicines, particularly against AMR, is not so attractive business in terms of cost-benefit balance. For pharmaceutical companies, new drug development and commercialization is a high-risk proposition. For example, in the United States, there was a company who developed a very good new medicine, but went bankrupt in 2 years after its launch. Antibiotics currently under development are not enough to keep up with the increasing of AMR, but still it is necessary to invest a huge amount of money to develop new medicines to manage tuberculosis and AMR bacterial infections, particularly gram-negative bacteria. New drugs need to be developed with no waiting time, but still it is also true that the risk is high, sometimes too high for pharmaceutical companies to accept. In July 2020, against this kind of a background, more than 20 pharmaceutical companies met together and established the AMR Action Fund. They set the target for new drug development, specifically to 4 new antibiotics over 10 years from 2020 to 2030. This goal setting is not the facade. In order to actually make it possible, pull incentives such as market entry rewards and subscription model are prepared to ease the entry into the market. Other models are being formulated as well. Such new models are introduced to create a more attractive target for investment. That is one element of this circle, promoting R&D and pushing forward venture businesses to formulate new antimicrobials. Running such cycles are advocated in this fund. For development of new drugs against AMR, care will be continued up until launch in the market. Such funding system is about to start in operation. On the other hand, very essential and important antibiotics that we have been relying on are found very fragile in terms of supply. In 2019, one of Japanese generic manufacturers stopped the supply of cefazolin, causing a serious confusion in clinical community. This news brought to light the truth that although this is not limited to antibiotics, but particularly antibiotics depend on raw materials supplied by foreign manufacturers. If something happened, it would cause discontinuation of the supply immediately. That is the reality we came to realize. Not only production, but also supply chain embrace a variety of issues around the business of antibiotics. This action plan calls for development of new drugs, but at the same time, how to maintain existing drugs. That is also an important issue, probably a new topic of discussion for the next action plan. The market of antibiotics is becoming more and more fierce. Development of new drugs, stable supply of existing antibiotics. There are a huge amount of issues. How to clear those challenges is a very important theme for the next action plan. Even in Japan, this year's supplementary budget plan, the first and the third, seems to be ready to offer 6 billion yen to secure the stable supply of existing antibiotics. That is an action to be welcome. It is important to keep such efforts. Needless to say, but I believe it is necessary to establish new models of a new drug discovery and development and the collaboration of industry, government, and academia. The last is international cooperation. That is multidisciplinary work with an international view on things to promote AMR control. In 2019, G7 leaders announced the following comment: "We will accelerate effort based on the One Health approach to tackle antimicrobial resistance, recognizing the UN Secretary General's report on AMR, which was informed by the recommendations of the UN Interagency Coordination Group on AMR and other relevant initiatives. We encourage all stakeholders, including international organizations, to act and coordinate on those items relevant to the missions that contribute to global efforts to combat AMR." AMR Research Center of NIID contribute their data to WHO AMR Surveillance Report GLASS, and AMR Research Center has modified JANIS, Japanese Surveillance System, for Southeast Asia and formed Asia's net for other countries, and that is now in place in Vietnam, Mongolia, Indonesia, and other countries. By helping establishment of this kind of surveillance system in these countries, collection and country-to-country sharing of surveillance information will be facilitated in the future. At the same time, there is another project to conduct a surveillance in collaboration with other countries. That is a tricycle project. The project that is the tricycle project is One Health AMR surveillance with a focus on E. coli, human, food, and environment. These three areas are surveyed altogether with E. coli as an indicator. The percentage of ESBL producing E. coli is calculated in this project. We hope to proceed this project in cooperation with WHO, OIE, and FAO. So AMR Reference Center and AMR Research Center in this year, in response to the request from WHO, they are going to be certified as WHO's AMR collaborating centers. Probably the two centers will have completed the process of certification by March next year and start their work as WHO's collaborating centers with expectation of expanding Asia's net, actively supporting tricycle surveillance and other international technical collaboration. In Asia-Pacific region and its surrounding areas, we have been making effort to lead AMR control with little achievement so far yet, but we are now making our strategic move. There are many AMR-related challenges in these regions. Tackling such international challenges will make a big return to Japan. In order to prevent AMR microbes from coming from other countries to Japan, we have to control AMR in these countries first. Japan's cooperation means a lot. And I believe we need to work together with WHO and to promote mutual cooperation and collaboration in the international framework. This table shows the result of AMR control based on Japan's action plan. This action plan has a specific targets and numbers, being unique in that sense. Various AMR bacteria and their control targets are indicated here. As you see here, some are very close to the target levels, but others are not. Targets are set for use of antimicrobials as well. It seems that we need to continue our effort further. This is about the AMR ratio of indicator microorganisms as of 2019. penicillin non-susceptibility in pneumonia that is good below the target. The fluoroquinolone resistance rate in E. coli shows a tendency to increase. This is a problem. The methicillin resistance rate in Staphylococcus aureus is better than before, but is still much below the target. Some more efforts need to be placed in the second action plan. The total sales volume of antimicrobials are on a decrease from 2016, and this is a very good news. Through implementation of this action plan, we are now seeing more good results, such as better service and better antimicrobial stewardship. The total consumption is also decreased, but still there are very many challenges that have to be solved. Stable supply of antibiotics and other newly recognized challenges included. We have to continue to tackle these challenges towards the future. It is critical to study the result and the challenges meticulously and to refresh our efforts in a more constructive manner. This is the end of my presentation. Thank you. Thank you very much, Professor Sugai. Next is Associate Professor Usui, Laboratory of Food Microbiology and Food Safety, School of Veterinary Medicine at Rakuno Gakuin University. Professor Usui is going to talk about the current status of antibiotic-resistant bacteria derived from animals from the perspective of One Health. Professor Usui, thank you. Professor Sugai has introduced Japan's action plan, particularly in human health care, so I would like to comment on the current status of antibiotic-resistant bacteria derived from animal to introduce current status and some project towards the future. As many antibiotics are used, the appearance and the spread of AMR bacteria is a serious problem. As Professor Sugai said in his talk, if we did not take any action to control, by 2050 about 10 million people would die of AMR bacterial infections. Such estimate is made. As a background to explain this situation, new antibiotics were actively developed from 1983 to 87, but the development of antibiotics of new mechanisms of actions are becoming stagnant these days. One thing we can say from this trend is that development of new antibiotics is not easy. So, how to keep and use existing antibiotics is a key. This is a global issue. Japan has drawn up its action plan and emphasized the importance of One Health approach. Professor Sugai gave us the overall outline of this action plan, so I would like to present what we have done in animal medicine. The rate of AMR in Japan's livestock industry is lower than in other countries. The discrete use of antibiotics need to be continued and further improved. I said the rate of AMR is low in Japan, but actually there are some antibiotics against which high AMR rate is observed. I'll mention that later in my presentation. About the reinforcement of AMR surveillance, collaboration work between human medicine and the livestock industry, surveillance in pet animals, companion animals, I'd like to introduce the project we are working on later in my presentation. As today's topics for discussion, the current status of AMR in animal fields, the use of antibiotics and the rate of resistance, antibiotics and the AMR genes in environment around One Health approach. I'd like to cover these topics in my presentation. First, about the current status of AMR microbes in animal fields. This chart shows the sales volume of antibiotics in 2011. Blue is human medicines, red is antibiotic additives in animal feeds, green is animal medicines, purple is agri-chemicals. As you know here, the quality of drugs matters. Relatively new antibiotics are more often times used in human medicine, not so much in animals. The quality of antibiotics used here is not consistent, but simply saying these statistics indicate the volume of antibiotic use is highest in animal medicine. This tendency was recognized even before 2011 and remains the same. Against this background, in 1999, Japan started a project named JVARM to monitor the use of antibiotics in livestock animals, the AMR ratio in indicator bacteria and the AMR ratio in pathogenic bacteria. As Professor Sugai mentioned, JANICE is in place in human medicine. JVARM is a counterpart in animal medicine, working from 1999. This is an example of information extracted from JVARM. This chart shows the use of antibiotics from 2001 to 2018 by different types of animals. The vertical axis is the total use of antibiotics, the horizontal axis is years and the types of animals. As you see here, the use of antibiotics is the highest in pigs. In this chart, the use is not so high in dogs and cats. And if you want to compare pigs and the chickens, for example, we need to be careful about different body weights of these animals, but antibiotics are relatively used a lot in chickens as well. Between cows versus pigs and chickens, there is an important difference on how to use antibiotics. In cows, antibiotics are given to cows individually. In pigs and the chickens, drugs are given to herds of animals. Like for fish farming, antibiotics are added into feed or water for them. This is one of the reasons that you see higher volume of antibiotic use in these animals statistically. This chart indicates the resistant rates of E. coli isolated in slaughterhouses of animals and chickens from animal meat from 2012 to 2017. From left side, cows, pigs in the middle, and a chicken in the right. The blue line is for tetracycline resistant rate. There are some increases and decreases, difficult to find a consistent tendency. But generally speaking, from 2012 to 17, the overall trend is almost unchanged with some ups and downs. As shown in the previous slide, the rate is low in Japan than in other countries, but the volume of use of antibiotics is high in pigs and chicken. In these animals, some antibiotics show more than 50% or close to 50% resistant rate in E. coli isolates. This means we have to do something to reduce this high level of resistant rate in Japan as well. Recently, the drug susceptibility of E. coli from companion animals has been paid attention to, and this is the result of a test of drug susceptibility of E. coli isolates from sick companion animals, dogs and cats. More than 100 specimens, each from dogs and cats, were analyzed. Carbapenem resistance or colistin resistance, which may cause serious problems in human medicine, were detected only slightly, not significantly. The resistance of third generation of cephalosporins or with fluoroquinolones were more often discovered in E. coli from companion animals as well. We have to take some action to control these drug-resistant microbes in companion animals as we do in humans. This chart compares the resistant rate of E. coli from sick dogs and cats versus livestock animals. The specimens were taken from sick dogs and cats, so the rate is higher than that from healthy ones. As compared to livestock animals, the appearance of drug resistance tends to be higher in sick dogs and cats, particularly with cefazolin, cefotaxime, and fluoroquinolones, the antibiotics which are more controversial in human medicine. This suggests that important antibiotics in human medicine may be used frequently for companion animals as well. I showed the data of current status of drug-resistant strains in animal medicine, higher volume of use in pigs and chicken, and high rates of resistance in the same groups of animals. The resistant rate tends to be higher in E. coli from companion animals for cephalosporin and fluoroquinolone. I want to show another set of data to show the use of antibiotics and the rate of resistance. This is about the correlation of the volume of antibiotic use and the appearance of drug resistance in E. coli. The volume of antibiotic use is plotted against the horizontal axis being the rate of resistance and the vertical axis the volume of antibiotic use. Cows, pigs, broilers, layers. As you see here, J-farm monitoring data show the correlation between the volume of antibiotic use and the occurrence of drug resistance. The point here is that the greater volume of antibiotics are used, the greater rate of drug resistance we will see. And in this study, we kept the pigs ourselves and gave fluoroquinolone antibiotics to them. The colonies of Campylobacter isolated from these pigs were counted later. The data show the changing of the appearance of a rate of fluoroquinolone-resistant strains in pig-derived Campylobacter. The top is the count of Campylobacters with and without resistance. The bottom is the count of Campylobacters with fluoroquinolone resistance. The vertical axis is the count of numbers. The horizontal axis is the days. Enrofloxacin and norfloxacin were used according to the manufacturer's instruction of use. The asterisks in red indicate the days when the drug was given. The total count of Campylobacters dropped temporarily after the administration of antibiotics, but later caught up and remained high. If you look at the numbers of fluoroquinolone-resistant Campylobacters, no such strains were detected before the administration of the drugs lower than the detection level, but they started to increase soon after the administration and kept high levels even after the discontinuation. This means that use of fluoroquinolone was associated with the later appearance of resistance. The selection of fluoroquinolone-resistant strains occurred. This is another study. E. coli was isolated from cows. The nature of isolated strains were compared between cows groups with and without a history of safety for treatment. Cephalosporin-resistant strains were isolated only from the safety for treated group. The use of safety for selected cephalosporin-resistant strains. This is another well-known data. For the vaccination against the Marek's disease, ceftiofur was added and inoculated into eggs in the past. This is data from J-farm from 2000 to 2013. The green line is cefazolin resistance in E. coli isolated from chickens. The resistance increased rapidly from 2000 to 2012. Here, people realized that this is bad news, that is a higher rate of resistance, and decided to stop the use of safety for vaccination. Then the rate of resistance dropped immediately. Again, the use of CFTO4 put selection pressure on E. coli for cephalosporin resistance. In 2018, colistin resistance came to an issue in human medicine. Colistin had been used in large amount in animals those days. The drug was mixed into animal feeds. The use of colistin as feed additives was banned in 2018. To clarify the relation between the use of colistin and the colistin resistance, we used piglets. Like we did for fluoroquinolone-resistant Campylobacter in pigs, we collected the data of colistin-resistant strains of E. coli from piglets during and after administration. The colony count of colistin-resistant strains was increasing during administration, but dropped thereafter. This is field data from pig farms. Before and after 2018, the percentage of colistin-resistant strains and that of E. coli strains with MCR1 resistance gene, the gene responsible for colistin resistance, were monitored. The positive rate of MCR1 decreased obviously after the ban of colistin. Again, the use of colistin was the selection pressure. It is obvious from these study data that the use of antibiotics is clearly associated with the selection of resistant strains. Professor Sugai showed target of drug resistant rates in action plan excluding animal data, and here these are the targets in livestock animals in the Japanese action plan. Tetracycline resistant rate, third generation cephalosporin resistant rate, fluoroquinolone resistant rate. The targets are set for 2014 and 2020 like this. The target of tetracycline resistance is 45% down to 33%. But when you look at the result of 2019, and this 33% is probably difficult to achieve. Based on the selection of a resistant strain by antibiotics, tetracycline and third generation of cephalosporin, fluoroquinolone, whichever the antibiotic is, in order to reach the target, we have to reduce the use of antibiotics. And how to reduce the use of antibiotics and the resistance, this is still a challenge. But we have studied some actions in animals. One example is the publication of guidebooks for the purpose to improve awareness among vets and producers. We need to reinforce our effort towards the future and to involve general people as well to widely share the correct knowledge and understanding about the use of antibiotics. This is the sales volume of antibiotics prescribed for companion animals. The data are sorted out by different families of antibiotics, originally manufactured for human use and animal use. Blue is the total volume of antibiotics for human use, red is for animal use. About 40% of antibiotics used in healthcare of companion animals are human use medicines. Sometimes human use antibiotics are used instead of animal use antibiotics. There may be some cost issue, but we need to shift toward animal use antibiotics for more proper use of antibiotics in animal health care. And this is a challenge particularly we have in companion animals. Guidance for discrete use and public education are necessary in healthcare of companion animals as well. This is the last topic, the relationship between antibiotics and the resistance genes in the environment. I have been discussing the use of antibiotics as veterinarian. The spheres of animals and humans are linked through animal meats. But nowadays, One Health approach has come into the spotlight. More comprehensive approach, including environment issues, is called for. One of the topics of importance under such situations is here. Antibiotics are used in animals, and the drug-resistant strains are selected and released into environment and further into humans. One element which exists in this route is farmyard manure. Feces of farm animals are raw materials of manure and compost. They are converted to manure and spread over the ground. I took particular note of manure. No detailed data here today, but the drug-resistant strains and resistance genes are reduced through the process of aerobic fermentation and composting. Aerobic fermentation of animal excretes generates heat. Heat kills harmful microbes, but when a study was done in manure and compost in Japan, drug-resistant strains of microbes were detected in about 55%. Resistance genes were detected in all tested compost. Action to improve the situation in the environment is necessary in the future as well. Composting is not enough to eliminate resistant strains and resistant genes. New method of composting, manure treatment may need to be developed for resistance control. This is not limited to compost. Water is also important environment to be monitored. Water may be more favorable environment for selection and maintenance of drug resistance. Dynamics of drug-resistant microbes in water and the concentration of residual antibiotics in water and drug-resistant strains were studied in Thailand. I'd like to share this information. This indicates the relationship between the level of antibiotics and the rate of resistance genes in bacteria. The vertical axis is the rate of resistance gene-positive aromatous subspecies. The horizontal axis is tetracycline concentration in water taken from drains of livestock farms, rivers, and sewage treatment sites. The higher the drug concentration, the higher the rate of detection of resistance gene-positive bacteria. We have some domestic data as well. Drug-resistant microbes of clinical importance survive in hospital drainage and rivers. I borrowed this data from Professor Azuma, Osaka Medical and Pharmaceutical Industry, my joint research partner. Samples were taken from hospital drainage and sewage treatment site. CRE was isolated with screening media. The count-resistant strains may be a little bit higher, but ESBL and NERP were also detected. Even bacterial strains containing NTM or CTXM55 were isolated from river water. These are domestic data. Again, comprehensive approach is necessary to analyze environment. These are domestic data, mainly from river water and hospital drainage, but from a viewpoint of animal care, farm drainage need to be analyzed in detail to understand the true status of drug resistance. As a conclusion, I discussed three topics. The resistance rate may change a little these years, but we need to take actions to reduce drug resistance in animal healthcare toward the future. There must be some ways to promote careful and discreet use of antibiotics. Monitoring and other specific approaches are necessary for environment as well. Monitoring is not well done for environment so far. Specific anti-resistance approach for environment is much less than human and animal healthcare. Collaboration with researchers in these areas is called for. And being away from today's topic, but looking at a COVID pandemic situation, I believe we have to do something to control extraneous resistant strains as well. One of our research themes, Clostridioides difficile, this bacteria may possibly come into Japan through imported animals. There is some data supporting this, and I'd like to show that. Clostridioides difficile, this causes antibiotic-related diarrhea in humans and has become a very serious problem in other countries, where strains of ribotypes 078 and 028 are particularly virulent and can infect people with high mortality rate. This ribotype 078 is detected in pigs and cows in other countries, suggesting the transmission between humans and animals. In Japan, on the other hand, they are less virulent ribotype strains were isolated. They can be virulent, but usually less virulent than those in other countries and harbor strains from animals. We did some study and isolated this 078 ribotype strains at a very high rate in Japan as well, particularly in pigs. In pig farming, farmers import boars from overseas. This is just my speculation, but this type of strains may have possibly entered Japan with boars. It may become transmissible to humans in future. This is not limited to livestock animals, but we should consider the possibility of resistant strains being imported from outside of Japan. This is also true for MRSA. We have to be on alert against importing of such microbes. In regard to the problem of drug resistance, we are involved in various studies about the food poisoning microbes, of course, and about the environment as part of One Health approach for diagnosis, alternative measure to replace antibiotics, and so on. We hope to continue and expand our research toward the future. I'd like to end my presentation with acknowledgement. Thank you very much. Thank you, Professor Usui. We have now received two professors' presentations. Professor Sugai talked about the contents of action plan, the activities and efforts of medical communities with the future challenges included. Professor Usui discussed the current status of resistant bacteria in animals and environment issues related to livestock industry. And this is a session to discuss One Health approach. So, first I'd like to ask both speakers from the viewpoint of your respective specialty healthcare of humans and animals. Professor Sugai, what to expect in the future in animal business, and Professor Usui, what to expect in human medicine. I would like to ask such kind of questions. I have an impression while listening to the discussions that the approach against resistance seems to be more advanced in human medicine than in animal healthcare. What is necessary in the future, particularly in animal medicine, Professor Sugai, would you like to start the discussion? Thank you very much. And thank you very much, Professor Usui. I think in both areas, human and animals, various actions have been taken already. But to take an example, we have been conducting in-hospital infection surveillance and collect data on the platform of JANICE for more than 10 years. The National Veterinary Assay Laboratory also has been doing a similar surveillance by the name of JVARM for many years. Actually, it was 3 years ago when I started to be officially involved in this resistance study. Soon after joining these efforts, I realized that One Health approach is very important and everybody agrees this approach generally. But in actuality, JANICE and JVARM, there is no mechanism so far to integrate the data from both systems, neither opportunities for researchers of both fields to meet and discuss common problems. One Health approach is still not in place when it comes to specific actions. Generally okay, but specifically little or nothing. One Health approach is still behind in many aspects. This is true for animal medicine and for environment study as well. Very few people are involved in environment AMR study, but there is no association, there is no academic society. Much deeper dialogues and joint studies need to be promoted. This is the feeling I have through my 5-year involvement in Action Plan. Fortunately, I'm a member of AMR Working Group of a Food Safety Committee and have a lot of meetings with the specialists of animal medicine and food science. But there must be much more of such opportunities for interactions among researchers. I try to hope to see such environment where many joint works burgeon. Thank you very much. Next is Professor Usui. In response to Professor Sugai's comment, I started to be involved in JVARM more than 10 years ago. I have an impression myself that One Health approach is raised as a subject of discussion much more oftentimes than before. So, yes, Professor Sugai is not yet happy with the situation, but I myself have impression that the opportunity of discussion among different specialists seems to be more frequent than before. Professor Usui, don't you agree? Yes, agree. Compared to the past, we have now JVARM and JANICE. People are willing to collaborate each other across human medicine and animal medicine. The situation is much better than 10 years ago when I started involved in JVARM. At the research level, mutual interactions are occurring, though it may be still small in scale, for example, to compare genes of bacteria isolated from humans and from animals. This is still a challenge, but I'd say that we can expect wider development of our joint effort in the future. Having said that, as Professor Sugai said, and I also made some comments in my presentation, environment is still difficult, still behind to study. What should be the indicator bacteria? There is no monitoring system in place so far. How to link human and animal medicines and the environment, that is still a big problem, I believe. Thank you. I may have asked you this already, but we heard various activities well organized in human medicine. What is your impression of this? And what kind of information or actions are necessary in animal medicine or livestock industry? Would you share your thought with us? Thank you. In human medicine, antimicrobial stewardship, discreet use of antibiotics, many things are going on in a visible and specific manner. We wish to see the similar progress in animal business as well. Their practice is very specific. Additional reimbursement for proper use of antibiotics, that is one example we wish to have in our business as well. But it is also true that the background differs between human medicine and animal medicine. It may be difficult probably if we want to copy and do the same thing as they do in human medicine. After all, in livestock industry, watching for proper use of important antibiotics, or I should say, providing information and educating producers, that may be sound idealistic, but developing such learning opportunities is most important. Thank you very much. Janice and J-Varm were mentioned before. Data from health animals on J-Varm and data from patients on Janice. Professor Usui presented some data from sick animals. Such data exist, but the population size is still very small. So how should we take this gap in data volume or population size? And when it comes to small animals or companion animals, they seek for professional health care. The population may be similar to those of Janice in that sense. Any collaboration or integration of Janice and the J-Varm data for comparison, is there anything which may happen? Do you have any comment on this? Professor Sugai, how about you? About companion animals, surveillance in companion animals continues. I think that is good news. But how to control infections? That problem may be more difficult in animal medicine because, unlike human patients, it is pet owners who receive the instructions from veterinarians, and regulations about the use of antibiotics are not the same. There may be some vet-specific problems there. So perhaps there must be some rules or consensus among veterinarian community. Infections or infectious agents do not move one way from pet to humans or from a human to pet. Transmission is bilateral. So besides healthcare surveillance, we need to build up evidence. That is very important, I think. That's all. Thank you very much. Professor Usui? Well, first, we need to think about the validation of data. Sick people in human medicine and healthy animals in animal healthcare. So the background of data generation differ. Data from sick patients versus data from healthy animals. To clear this gap, it is true that we need to look at the resistance rate with the data background taken into consideration, but keep collecting data in a consistent manner. I think that is important as well. We have to understand the background of data collection and present the data together with background information to experts. Probably it is left to experts how to read the data. With that information, while the presented expert would be able to interpret the data one by one. I think that is more reasonable. Thank you very much. There are still many things missing in veterinary medicine. I feel I have to admit that. In the last part of your talk, Professor Usui, you talked about important resistant strains like COVID or NDM. Border control draw lot of attention in these days. In the case of COVID, full-scale control measures are taken at airports and other places, for example, to control the entry of virus. But how about imported infections in humans? What kind of measures are taken? Livestock animals, small animals, pets, and companion animals, they are under legal control of Infectious Disease Prevention Act. Infectious pathogens can be dealt with according to this law, but when it comes to E. coli or other general common infections, they are not covered by current regulations. How should we do? Would you comment on that? I would like to comment on that. That is the same in humans. Most of them exist in the guts of people. Most of resistant bacteria are not so virulent to cause overt symptoms. They may be brought in as part of normal flora in human bodies from overseas and detected on test by accident at hospitals, or infections may occur outside of Japan and be brought in the body of a sick patient who are tested and diagnosed in Japan. In such cases, it is allowable to force test on patients themselves, but we cannot do that to their family members. Even if we want to do that, that is not allowed. Following them as a cohort, even that is not allowed basically. So, border control over potential entry of infectious agent from outside is actually impractical. So with that kept in mind, what we have to do, in many cases, the source of infections which may enter Japan is China or Southeast Asia. Promoting AMR control in these countries will help reduce the entry to Japan eventually. In that sense, they may have their own ideas, but how to support AMR control in these developing countries is a matter of importance. Using our resources, including software, AMR surveillance platform may need to be established in these countries of Southeast Asia, helping them to develop their AMR control systems may eventually result in a lower risk of AMR entry to Japan. Again, international collaboration need to be sought for that kind of goals. This time, AMR Research Center has been nominated as AMR Collaborating Center. We hope to accelerate such international collaboration work. That's all. Thank you. Professor Usui, how about you? In regard to this issue, again, animals imported from overseas are difficult to regulate in Japan. as Professor Sugai suggested, import sources need to place certain level of regulation before shipping out to Japan. AMR control on overseas or overseas sources may be more effective to reduce drug resistance worldwide. So I agree that international collaboration work is a more realistic approach to reduce the risk of resistance as much as possible. Thank you. In terms of collection of information at import sources, they conduct surveillance in livestock animals for those known as livestock MRSA or LA-MRSA. They have been doing that kind of surveillance quite actively since 2005 or so. But still in actuality, many piglets are imported from Europe, allowing the entry of microbes together in piglets. Collecting data is not enough to prevent the entry of microbes. It is true that there is a little thing we can do at the current situation beyond that, but there must be something we can do that is a challenge we need to solve in the future. That is my personal comment. One more thing I would like to ask about. As discussed before, there is some discussion on environmental study. Surveillance has studied already in Japan, as Professor Tsugai said before. But how they want to do overseas in terms of the project or approach for environment, could you share that with us? Yes. As I presented one case in one of my slides, the project I've been involved is the tricycle project. The use of E. coli, ubiquitous bacteria, as marker to monitor ESBL producing strains, resistant strains in foods and the environment. This is rather a simple indicator. WHO took the initiative to start this project, and in the future, from 2021, they plan to upload the result of the survey onto GLASS. They have requested all WHO member states to join this program. The purpose is to solve difference in AMR indicators among different countries. The expectation differs from country to country, and there are many countries who cannot live up to such a high level or complicate the level of indication. WHO has come up with ideas of using a rather simple indicator that is the indicator of this tricycle project. There must be something brought into a spotlight through comparative analysis of situations in humans, environment, and foods. Probably they want to clarify more the situation of RIMIC countries or developing countries, but the WHO encourages developed countries to join this project so that they can have a global data. That's why they have decided to put the information of this survey or tricycle surveillance on GLASS, as I understand. We are now approaching several researchers as in AMED study, including Professor Asai and other university professors, for the goal to find what we have to do to sustain stable provision of data from Japan. We have made the first start just recently. WHO was the only international organization involved in this project until this year, but FAO and OIE have decided to join, and that built a tripartite tripartite relationship, and eventually environment issues will also be covered in this project. As the steering group gets bigger, their move may become slower, that is a concern, but for the time being we want to focus on data submission from Japan, that's all. Thank you. Professor Usui, you may have presented an example of Thailand in your presentation, but the issues such as the treatment of sewage and livestock drainage, Thailand and Japan may have different problems. And what will happen as a result of data collection in these developing countries may be not beyond our imagination, but what they can do. Do you have any idea about control measures? Well, I feel sorry I cannot make a clear answer, but they are still developing countries, and that may be also true in livestock industry in Japan. Professor Azuma, Osaka Medical and Pharmaceutical University, my joint research partner, did some study in water from rivers and hospital drainage. They would say that the ozonation treatment is very effective to kill microbes with non-resistant genes, but such technique is not practical in the fields of livestock industry or developing countries. Even if they are very effective, how to lower the cost of such technology to affordable levels is a big challenge. Ozonation system has become much cheaper than before. Many people say that, but still, actually calculation of a cost proves that a hardship. It may be up to the manufacturers of the system, but how to make it practically usable and affordable is a challenge, although we know that it's effective. Thank you. May I make a follow-up comment? We do AMR study in Japan and Vietnam. Japanese researchers working in Vietnam told me that Vietnam is still at the developing stage, but they are very conscious about the environmental issues, the importance of environment issues. They want to have evidence. Based on the evidence, they want to decide allocation of available resources for water management and wastewater treatment and others. So if the governments truly feel a need to solve such problems and interested in such techniques, it is important to get the involvement or national organizations involved in this kind of project. I think that is very important. Thank you. Thank you very much. We wish to continue this discussion, but it seems that we could have a very good general discussion. So I would like to finish this session now. Thank you very much for your excellent lectures. This session is over. Thank you very much. Thank you.